is indeed a privilege to introduce a person of great eminence, Dr. Vijayshri Dhyani, to you. She is a doctorate in evidence synthesis. And in MAHE, what I know is she is a consultant to all the systematic and scoping reviews which are being done under the aegis of MAHE. We all know that we have Director of Health Research in New Delhi. They have their MAHE has one collaboration with that center, which is MAHE Directorate of Health Research and Technical Resource Center. She is a team member of that. And under that, she has got many projects, one of which has formed what you can say a high value, that is the first national evidence-based guideline on lung cancer. And that is a great tribute to her also, and it has feather in the cap of our university also. And she is what you can say the scriptwriter or the main person behind that guidelines. Amongst her other projects, she is again involved in making guidelines for osteomyelitis, septic arthritis, and depression. It's indeed a great privilege to have her as a principal speaker for this. I know she has the art of making this tough subject very easy for all those who are beginning to in this field or are thinking of going into this field. And we all know that systematic reviews forms the highest level of evidence. And this is something where you may not be doing an active research, but you will be doing something which people have already done. If somebody cracks this art and somebody learns this art, probably he will become a very learned person in urology community. That I'm very sure. And if you see we have hardly, uh, uh, we can just number on our fingers the people who are actually involved in all this type of study, which is still the highest level of evidence. With this purpose in our mind, we just scripted the program of ASU Research Cell in making our members know that this is a subject where if they go a little bit with passion and dedication and learn the tricks and form a good team, collaborate with good people, they can script some good papers, good publications with some research question. And Madam is there to help us in knowing all these tips and tricks. With this, I'll also welcome Dr. Arvind Ganpale, who is the expert for this session. Dr. Arvind himself is again has many systematic reviews to his credit, a past associate editor of Indian Journal of Urology, and befitting comments from him, quality comments from him after the end of the talk will be very useful for all of us. With this, I think without wasting time, I'll hand over to Dr. Vijayshri to please start the proceeding.
Thank you. Thank you so much, Dr. Arun Chawla, sir. It's indeed my pleasure to be a resource person for this workshop. And for lung cancer guidelines, it was led by Dr. Naveen Salins, who is also Director of Research at Manipal Mahe. And there were other team members also, so I was part of it. So yeah, I think I shall start now the presentation. Okay. So I'll be sharing the presentation. Is it visible?
Not yet.
No, madam, not
go
yet.
To share. Go to share and.
Okay. Share. Yes. Is it visible now?
Just hold on.
Yes, yes. It's coming.
Okay.
Yeah.
Thank you. Thank you.
Slideshow, and then you're good to go.
Yeah. So is the slide show is there?
Yes, madam.
It's visible.
Oh. Thank you. Thank you, sir. So I'll just stop my video and I'll start the presentation. So today's session is Introduction to Systematic Review, where we will be mostly talking about what are the different steps of a systematic review and what is the difference between systematic reviews, narrative or traditional reviews, and meta-analysis. Next would be develop focus research question using the PICO framework. that is population, intervention, comparison, and outcome. Define inclusion and exclusion criteria, prepare a review protocol following PRISMA guidelines, and develop search strategies for database, PubMed, Embase, and Cochrane. So I will just touch upon all these steps in very like brief, because it takes a lot of time to discuss each in detail. So we'll be briefly talking about each of these steps one by one. So, firstly, I'll be talking about evidence-based medicine, because systematic reviews forms an important component of an evidence-based medicine. So, when we talk about EBM, it is a systematic approach to clinical problem solving, which allows the integration of the best available research evidence with clinical expertise and patient values. So, there are three core elements to EBM, which is clinical judgment that comes with the consistent uh, experience. Then there are relevant scientific evidence which are in public domain, which are published literature. And then there comes the patient values and preferences, okay, which are of most important when we are introducing a new intervention or a drug. So these are the three core elements of EBM. So when we talk about clinical judgment, it is the clinicians his or own judgment, patient values and preferences, and relevant scientific evidence. So when we talk about relevant scientific evidence, so where should we gather the information from? So that is where systematic reviews plays an important part. So now, before I start with the systematic review and its itself, we will see what are different types of reviews that exist. You might have heard of different types of reviews, but here we will be seeing first is the narrative reviews or the traditional reviews. So what we see when we do a narrative review or a traditional literature review, that we analyze and summarize the existing literature. There is no structured methodology as such. That is why it introduces subjectivity and bias, and it lacks rigor. And it provides a descriptive key concept and relevant finding of research topic. So this is the narrative review or traditional literature reviews that we do in general. Okay. Then there comes the scoping reviews also. So you might have heard nowadays scoping review and systematic review, and there is a lot of confusion regarding which one to take. So there is a difference between a scoping review and a systematic review. So all the reviews, these are for different purposes. So when we do a scoping review, so as such, when we say scoping review, so we try to identify the types of available evidence in a given field, or we try to clarify the key concepts or definition in the literature, how quality of life is assessed over the years. So that could be one of the review question for a scoping review. Or what are the quality of life questionnaires are available for urology related issues. Okay, so that is one of the question that we can take for a scoping review, where we are trying to clarify the concept and definition that are evolving over a period of time. Then it can be also used how research is conducted on a certain topic or field. So what are the study designs, what are the methods that have been used. Okay, then to identify key characteristics or factors related to a concept. Okay, so what constitutes a quality of life, or a health related quality of life, or activities of daily living, for example. Or it could be also a precursor to a systematic review. So when we are unsure about whether to go for a systematic review or not, and how much evidence is available, whether it would be feasible to do a systematic review or not, then we do a scoping review as a precursor to a systematic review. And it is also used to identify and analyze the knowledge gaps. Okay, so this is scoping review. Next comes the systematic reviews, which usually when we do, as it says, it's a systematic process that we follow. And when I'll explain this different steps of a systematic review, then we will get to know why it is called a systematic process. Okay, so it confirms the current practices, addresses any variation, identifying new practices. Okay, then identify and investigate conflicting results. So from certain trials we are getting conflicting results, so to see, okay, which side it is going, whether it is favoring the treatment or not favoring the treatment. So what is the ultimate conclusion? Okay, for clinical decision making, produce statements to guide decision making, and whether a meta-analysis is possible or not. Okay, pooling the results, the quantitative pooling is possible or not, that is what a systematic review, that is why we do a systematic review. So these are the some of the main types of review that are there. Then there are other reviews also, which are like umbrella reviews, where we include all the reviews that have been conducted in a particular PICO concept. And then there are rapid reviews also, where we streamline certain processes of the systematic review. So those are other types of reviews. So here, this table basically depicts what are the different characteristics or differences between a narrative, scoping, or a systematic review. So when we see this, so first, if you can see here, a priori protocol. Okay, so for a systematic review, it is a mandatory to have a protocol. Okay, so we should have our methods before we start the process, before we start including the studies. Okay, so we have a all the methods in a documented paper with us. For a scoping review, for some, yes, it is mandatory, for some it is not, and for narrative review it is not there. Okay, so a priori protocol, it is a must for a systematic review. For scoping reviews, nowadays they are also asking a protocol for a scoping review. Then Prospero registration of the review protocol. Prospero registration, again, it is a mandatory for a systematic review. If you are trying to do a systematic review, you should register it on Prospero. So Prospero is the registry where we register, we have all our methods registered on the registry, so that there should not be any duplication. Okay, so for all those reasons, scoping review, again, scoping reviews are not registered on Prospero, but there are other registries for scoping review. And nowadays it is also necessary to get it registered, like OSF is there, Open Science Framework. Okay, so there are registries for scoping review as well. And again, for narrative review, it is not there. Then explicit, transparent, peer-reviewed search strategy. Okay, so to have the search strategy means we need to, you might have heard of different databases that are there. So we need to search on different database and develop the search strategy for that. So for scoping review, it is a must. For systematic review also, it's a must. And for narrative reviews, it's not a mandatory requirement, or it is not done usually in a narrative review. Then standardized data extraction form, again, for scoping review and systematic review, it is a must. Mandatory critical appraisal or risk of bias assessment. Okay, so for scoping review, it is not a mandatory requirement, but for a systematic review, it is a mandatory step that we have to follow. Okay, so what is the quality of the studies that we are going to include, or how much is the bias in the studies? And then synthesis of findings from individual studies and the generation of summary of findings table. So for narrative and scoping reviews, it is not done. And for a systematic review, it is done. Okay, so these are some of the key differences between narrative reviews and systematic reviews and scoping reviews. So there are these two resources that you can check. One is typology of reviews, that was by Grant and Booth, and they had a SALSA framework for defining 14 different types of reviews. SALSA stands for search, appraisal, synthesis, and analysis. Okay, so this is the framework that they had utilized for differentiating 14 different types of reviews. So that paper you can have a look. Another is systematic versus Scoping review. So when you have this confusion or dilemma whether to go for a systematic review or a scoping review, you can see this resources. So there are pointers that will give you whether you should go for a systematic review or a scoping review. So next is within systematic reviews also, there are different types of systematic reviews. Okay. So it could be effectiveness reviews. It can be etiology or risk factor related. It could be experiential or qualitative, diagnostic test accuracy, prevalence or incidence, or prognostic. So these are some of the types of reviews that can be done within the systematic review domain. Okay, so what we will be talking about today is a effectiveness review. That the framework we will be using will be PICO, that is population, intervention, comparator, and outcome. For a etiology or risk, for example, smoking, how what is the association between smoking and lung cancer? So that way it will be PEO. Experiential or qualitative, where we are seeing the patient or caregiver's perspective on uh, certain new drug or procedures that needs to be done, or healthcare providers perspective. So that also is very important when we need to make a decision. Okay, then there is diagnostic test accuracy, where we are testing diagnostic test versus other. Okay, so the framework for it is PERD, that is population index test, reference test, and diagnosis of interest. Then there is prevalence or incidence, that COCO POP, that is condition, context, and population is the framework. And there is prognostic, and its methodology is still evolving, and it is population, prognostic factors, and outcomes. So these are some types of systematic reviews that are there. There are others also. There are reviews on methodologies. There are reviews on economics related reviews, okay, which talks about cost effectiveness and others. So here, from now onwards, we will be talking about systematic reviews of effectiveness, where we are comparing intervention A versus intervention B. So these are some of the best tools and practices. That was by Kolaski 2023 document, and this is the consolidated table they have made. And you can see here there are different, this green box, you can see there are different uh, types of reviews, systematic reviews that we were talking about. And Cochrane is the gold standard for most of the reviews. Okay, and JBI also has Joanna Briggs Institute, they also have methodologies for all these kinds of reviews. Okay, and we can see that for umbrella reviews is a review where we include only reviews and not the primary studies. Again, scoping review, we only have guidelines by JBI, AXI, and OMLA. That was the previous guidelines, and the Prisma SCR reporting guideline. For systematic review, we have Prisma P for protocol, okay, and Prisma for the review itself. Okay, so these are some of the best tools and practices that are there for systematic reviews. So now we'll come to the systematic reviews of effectiveness of intervention. So when we say that a systematic review, so what does it mean? It is wherein we try to identify, appraise, and synthesize evidence to answer a focused review question or research question. Okay. So the aim is to minimize bias by using explicit systematic methods documented in advance with the protocol to produce reliable findings to inform decision making. So these are the this is the systematic review in its, okay. So now, there is also confusion whether a systematic review, if it is not having a meta-analysis, whether it is called a systematic review or not. Okay, some people, some students, when they come, they are very confused whether if a meta-analysis is not possible, so whether it will be a systematic review. So answer is yes, it is very much of a systematic review if we are following all the steps of a systematic review. So meta-analysis sometimes is possible or sometimes it may not be possible within a systematic review. So meta-analysis is basically a quantitative part of SR which statistically aggregates the results from two or more studies. So that is what meta-analysis is done. So this is another resource, what review to do. Okay. So if you want, you can just go through this, write review. You can type in Google and see how it works. Okay. So it will give you a series of questions that what you want to do, whether you want to compare intervention A versus B or like that. So there are series of questions and it will give you answer what kind of a review you can do. So you can explore this resource later. Okay. So now the key points related to a systematic review. So first is it has a very highly structured format which followed Cochrane handbook, and Cochrane is considered to be the gold standard for conducting the systematic review. Systematic reviews often are exhaustive, requires time and involve a team. So it is very important that you plan a review in a manner that you have the enough time to complete that review and you have the team. So it is very important to have a team wherein all the team members can contribute or should be contributing. So sometimes it is only one person who is doing. So when we are making or forming a team, it is very important that uh, each member of the team contribute to the review process. Okay, and review team can include a subject expert, statistician, methodological expert, and other people can also be there. So these three team members should always be there. Okay, and at least three members are needed to do a systematic review. Okay, then it has a rigorous and explicit methodology and it follows PRISMA guidelines. PRISMA is preferred reporting items for systematic review and meta-analysis. PRISMA P, when you are drafting a protocol, that time you should follow PRISMA P. So there is a checklist that you have to go through and see if all the points are there in your protocol or not. And Prisma is the checklist for the entire review when it is completed. And protocol registration, the registration of any systematic review is done on the Prospero. So it's a registry where you can see all the systematic reviews that are in plan or have been completed. So before we even start the review, okay, or thinking about the review, so we have a rough idea about the topic, about what population we are catering to, or what are the intervention that we are taking into consideration. So before we start the review, okay, when we have a rough idea about the review, we should always search for similar reviews. Scoping search on PubMed, Prospero, Cochrane Library, and JBI Evidence Synthesis. So these are the four databases that we should search, okay, if any related reviews have been published or not, okay, so that there should not be any duplication. And also you find the rationale for your review. Okay, so what is the gap in the existing reviews that you are trying to fill with your proposed review? So it is very important to see what are the similar reviews that have been conducted so far or ongoing also. Okay, now we will be talking about systematic review steps. So first step in a systematic review is review question. Okay, once you have done the search on different databases to see whether any existing review are there or not, and then you frame your review question. Okay, objectives, aim, PICO elements, that is population, intervention, comparator, and outcome, and eligibility criteria. So this is the first step of a systematic review. Then second is the search. So with the amount of publications that we are having these days, there is enormous amount of publications, okay? And post-COVID, it's so many are there, okay? So we need to search on different databases. So there are Medline, Embase, Central, Scopus. There are many databases that can be searched. Okay, then there is a selection process, how we are going to include the study. Okay, so that is called study selection or screening. Select evidence for inclusion. Okay, based on our PICO eligibility criteria, we will select the studies for our review. Okay, and this also is done in two different stages. Next step is risk of bias assessment or quality assessment. And so this step along with the next step, data extraction, sometimes it is like done together. Sometimes they do data extraction and quality assessment together. So it's like you can go together or it can be like fourth or fifth. It's not a hard and fast rule. Okay, so risk of bias assessment, where we assess the quality of the studies that we are including or the bias that exists in those studies. Next is our data extraction. So what kind of data we will be extracting from the studies to have our review. Okay. And next step is the data synthesis, which can be either meta-analysis, narrative synthesis, and grade assessment. So each of these steps we will be discussing further. So first is formulation of a review question. So when we are formulating a systematic review question, we should state the question following the PICO framework, okay? And it is very important for clearly framing the eligibility criteria, searching for studies, collecting data from included studies, and presenting your findings. So at each step of the systematic review, this PICO framework will be very helpful. Okay, so this you have to, when you are deciding your review, that time these PICO and eligibility criteria should be given due consideration. Okay, so you should have enough time to finalize these PICO and eligibility criteria. So how a review question should look like? So a review question should look like: in population, what is the effect of intervention on outcome compared with placebo, usual care, or another intervention? So this is the format of a systematic review question. So this is the example. This is a published review that I have taken here for example. So in adult men with advanced prostate cancer, does robot-assisted radical prostatectomy improve outcomes compared to LRP, laparoscopic? Okay. So this is the, so you can see here that we can identify the PICO element or not. Can you identify the PICO element here? Okay. So this
Yeah,
is,
population is
yes,
advanced prostate cancer men.
yes. Intervention. So population is adult men with advanced prostate cancer. Okay. Intervention is robot assisted RAP, and comparator is LRP, and improved outcomes. Outcomes can be of different types. It can be functional outcomes, it can be other outcomes. Okay, so that we will see later. So this is how a review question looks. So I told you before that before going for a systematic review, we should register it. So this is a review that has been that was published in 2025, and you can see that on Prospero they have registered the protocol. Okay, all the steps of a systematic review, all the methods that they are going to follow in a systematic review, that they have registered a priori. So before starting the review, they have all the methods in place, okay, which are registered in Prospero. So this is the review that was published. Okay, you can see here. And here we can see the Prospero number also is mentioned. So it is a mandatory step for a systematic review that we register our protocol in Prospero. And it is always when we are going to publish our review, that time they will ask for this registration number. So it is a mandatory step for a systematic review. So next we can see the eligibility criteria. So eligibility criteria of any systematic review, again, the same PICO criteria. So what are the consideration when we are we are deciding on these criteria. Population can be in terms of disease or conditions of interest, or demographic factors also. Like in the previous example, we saw men with prostate cancer. Okay. And it could be any geographical region specific also. That depends on the review question and the clinical utility and importance of it. Then intervention or exposure, comparison, outcome can be primary or secondary, and critical or important outcomes. And other consideration for an eligibility criteria could be study design, time frame, and geographical region. So study design, are we going to include only randomized controlled trials, or are we going to include only studies from 2000 onwards? If from 2000 onwards, what is the justification for that? So when we are deciding the eligibility criteria, usually if we are doing a intervention review, we should not restrict it to any time frame. Only when there is a justification that, okay, this intervention was like came in 2000. Okay, so that way we should decide on the time frame. Otherwise there should not be any restriction on time frame. Okay, then there is a geographical region also, whether you want to restrict your systematic review only to India or South Asia or LMICs. Again, why you want to do that? So that justification has to be given. Okay, so we can see the same example we will follow here. Okay, comparative effectiveness of LRP versus robotic. Okay, so what is the population here? Men with clinically localized or locally advanced prostate cancer. So intervention is RAP. We can say RAP here, robot assisted. Uh, comparator is conventional laparoscopic, that is LRP, and outcomes are functional outcomes. So what they are considering are functional outcomes, urinary continence or sexual potency, perioperative outcomes or oncologic endpoints, positive surgical margins, biochemical recurrence, or PSA control at a minimum follow-up of 3 months. Okay, so that also, when they are telling about PICO, they are telling when, at what time point they are going to measure these outcomes. Okay, so at a minimum follow-up of 3 months. Yes, sir. Hello.
Go ahead, ma'am, please.
Okay, sure. Thank you. So you can see that this is from the publications that I have taken, Mirza 2025. So you can see an eligibility criteria is not only about inclusion, it is also about exclusion criteria. What are the studies that you are going to exclude and why? Okay, so all these things you should consider when you are drafting your protocol. You can see we included studies that met all the following criteria. Okay, and here, okay, see here, randomized control trial. They are only including randomized control trial, directly comparing RAR with conventional LRP, 2D or 3D. Okay. Then adult men with histologically confirmed localized or locally advanced prostate cancer. So this way you have to clearly in detail, you should specify your eligibility criteria. Here they are telling that they are not including any non-randomized studies, prospective or retrospective cohort, case series, case control. Okay, and even for the intervention and comparator also, they have a exclusion criteria. Okay. So next is the search. So once we have defined our research question, review question, and eligibility criteria, next is the search. Okay, where all we need to search and how we are going to search, and it is one of the most important step in a systematic review. Okay, so it should be comprehensive as possible within the constraint of time and resources to identify published and unpublished literature. Okay, so we should consider the time pipeline that we have and the resources, like how many team members are there, so that is how we are going to search the studies. So where to search, where we are going to search all these studies? So as you know that we have different databases. Okay, so these in the green one, Medline, Cochrane Library, that is central, and Embase, these are the three mandatory databases that we need to search when we are doing a systematic review of health related question. Okay, there are other databases also, Scopus and Web of Science. Scopus and Web of Science are multidisciplinary databases. That also, one of it we can take. So for Mahe, we have access to almost most of these database, except I think PsycInfo and EconLit, I guess, but most of other databases we are having. Okay, so Sinhal is for nursing related reviews. Econlit is for economics related studies. Pedro is for physiotherapy. PsycInfo is for psychiatry related. So all these databases are there, but three are must. These three are must. That is Cochrane Library, Medline, and Embase. Okay, then we can also search gray literature. It could be in form of government reports, conference proceeding, thesis, ProQuest. ProQuest, again, we can find the thesis and dissertations there. ProQuest is the database. Shodh Ganga is a repository of PhD thesis in India. Then again, Google Scholar also we can search, but we have to make it explicit whether we are going to use the gray literature or not. If possible, we should be using gray literature. Okay, but in most of the reviews, you will find that they only go for electronic databases because it is easy. Gray literature, it is difficult to access all the things, especially if we are doing a global review where we are including studies from all over the world. So that becomes difficult, but still we should try and search for gray literature as well. Gray literature is something that has not been published in scholarly journals, but as reports. Then hand searching. So certain journals which are not like very high quality journals, or which are not indexed in these databases or poorly indexed, so those can be hand search. Okay, we can go to their website, and from there, hand searching means not only physically hand searching, but going to their website and searching like each volume and issue. Like that we can search. Okay, if it is relevant to our question, then only we need to search that journal. Okay, if it is not indexed in Medline or Cochrane Library or Embase. Okay, then contacting experts. You can also contact experts if they know of any study that has been published. Okay, so they can also be contacted. Then citation searching. So the studies that we have included in our review. So
Listen.
okay, so citation searching is like the studies that are meeting your eligibility criteria. The reference list you can go through, and you can see if any relevant articles you can get from there. So that is hand searching. And fourth is our websites or guidelines. So we can search WHO, Clinical Trial Registry, International Clinical Trial Registry platform, and other websites which are related to your subject domain or eligibility criteria. Okay, so these are the important resources that we need to search for all the types of studies. So how we are going to search? So it should also be well documented in your protocol. Okay, so here you can see a comprehensive electronic search was performed in major bibliographic database and trial registries from inception to October 31st, 2025. So again, it is very important that you have this timeline. Okay, you can see that from inception of the database till October 31st, 2025, they have searched. Okay, and then without any language restrictions. In Medline via PubMed, Embase, Cochrane Central. Cochrane Central is trial registry. Scopus, Web of Science core collection, and clinical trial.gov. So all these databases and trial registries, they have searched. Okay, were searched using combination of controlled vocabulary and free text terms. Okay, related to all these important keywords that they are having, and randomized trial filter where appropriate. The reference list of all eligible studies. See here, we can see the reference list of all eligible studies and relevant reviews were manually searched to identify additional trials. The full search strategies and yield by source are presented in supplementary file 1. So it is also one of the mandatory requirement to have all the search strategies or at least of one database as a supplementary file. So all these things should be documents. How many databases you have searched, what was the timeline, okay, what was the different keywords and control vocabulary that have been used, okay. So all these should be documented, and here we can see that for PubMed Medline, they have this search strategy that is called, this is called search strategy. This is search strategy. And from Medline, they have got 438. From Embase, they have got 712. And others, I have not kept it here, but they have a full supplementary file. All the numbers are documented. Okay, so this is again very important step in a systematic review. So now how we are going to develop the search strategy. So there are 4 steps to it. First is identify the key concepts from research questions. So again, what can be those key concepts? Key concepts can be in form of PICO, okay? Or for a scoping review, it is population, concept, and concept. This we will not look at right now. Okay, we'll see here population, intervention, comparator, outcome, publication type, geographical region. So these are some of the important concepts that can be used to develop the search strategy, but it's not like all you have to use. So you have to see which are the important concepts that should be there. Okay, so this is one. First step. So see, if this is the example I'm taking here, effectiveness of palliative care and end of life care intervention for cancer to improve quality of life in South Asia. So we can find the PICO element here. Okay, so important concepts are palliative care and end of life. Again, cancer is the population, people with cancer. Quality of life is the outcome, and South Asia is the geographical location. So these are the 4 important concepts. Okay. Second is our identifying key terms related to that concept. Okay. Key terms. So for cancer, we can see the alternative terms for it, like tumor, leukemia, okay, neoplasm, mesh term. For PubMed, we can search neoplasm. Malignant neoplasm is in Embase. QOL. The abbreviation also we need to search. If it is like quality of life, so we also should be using QOL or HRQOL for health related quality of life. So that is how we identify key terms related to concepts. So third step is develop the search strategy. Now that we have identified the concept, from concept we have identified the related terms, from this we will develop the search strategy. Okay, so how we are going to develop the search strategy? We are using Boolean operator and field codes. These are the 2 important things that we will be using to develop the search strategy. Okay, so Boolean operators, you might have heard that or, and not. So these are the 3 important Boolean operators that are there. Okay, so Boolean operators, when we use or, cancer or tumor, so it will have all the articles where either cancer or tumor is there. When you're using and, then it will look for the articles where cancer and quality of life, both the term will be there in the same articles. Okay, so it will narrow down the search, or will broaden the search, and will narrow down the search. Okay, and then field codes is where do we want to search a particular term, like cancer. If it is a cancer, so it would be in title and abstract or all fields. Okay, so that is how we use the field codes. And other things are there, truncation, wildcards, that I'll be talking about next. So once you develop the search strategy for PubMed, then you have to, this is again not, okay. So like this, you will be having a search strategy for you, and this, it will be, you will be translating it to other databases. Okay. So then there is a phrase search also. So there are terms like which are like exclusive breastfeeding. Okay, so there are 3 words in it. So when we want to search it as exclusive breastfeeding, so you can see you have to put it under quotation marks, within a quotation marks. Okay, otherwise you can see the difference between the two. When we have search exclusive breastfeeding within the quotation marks, it is giving us 1, 2 to 6 hits. Okay, when we have just used exclusive breastfeeding, it has given us 58,000 something. Okay, so it is very difficult to look for 58,000 papers. So that is how we use the phrase search when we want to see certain terms besides each other. Okay, or as a phrase, exclusive breastfeeding, heart attack, or others can also be there. Okay, breast cancer, lung cancer. So when we are using the two term as a one phrase, then we should be using this quotation mark. So these are the key terms that we have identified. So this, when you are developing your search strategy, this table you should have. Okay, these are the important concepts that we have identified. Okay, these are the text terms related to them. It can be spelling variants. Okay, then it can be also abbreviation. Related to all the concepts, we have to we should try to fill this, populate this table, okay, as far as possible. Then for geographical location, South Asia, like this. Okay, next is truncation. So truncation, again you can see that this asterisk, okay, or a star, when we put with therapy, okay, THERAP star, it means that it will look for the therapy, therapies, therapeutic, therapeutics. Okay, and at least 4 words should be there when we are using this star truncation. Okay, for child, so different databases, difference can be there. So for each of the databases, you have to go through the user guide and see what are the truncation that they use. Okay, so this is for most of the database, the star. Okay, and if it is for a uh, quotation, then it should be within the quotation. Okay, and it should be with the last word for PubMed. Then there are wildcard also, which like woman organization. So when we know that there are some spelling variants, okay, and there is some spelling variants like woman, WOMAN, WOMEN, plural or singular. Okay, that way we can use these wildcard, single letter truncation. So this will search both for women and women. Okay, organization, it will search for both S and Z. So there are spelling variants also, so that you need to consider. So it is not always mandatory to use these wildcards, but if you feel there is a need and it can be worked out, then you can use these wildcards. Then proximity searching. Proximity searching means, like for Embase, usually proximity searches in PubMed we don't see often, but for Embase we can see that proximity searching. Okay, when two words are, like the word must be within n words inclusive of each other in the record. Okay, when we see that parent and relationship can appear in a sentence where there could be the distance of 2-3 words, so that way we need to search like proximity operators. Again, it is not a must, but it can be used. Okay, so then there are, for each of the databases, there are search filters. So you can see on the left hand side, these are the search filters. So it can be in terms of age, or it can be in terms of years, in terms of study design. Okay, but better not to use these filters. If only we are using, we should only use publication date and language. It is advised not to use filters otherwise. Only in the initial stage, when you want to look for systematic review related to your PICO question, okay, that time you can use that filter, but not when you are actually searching for the studies for your systematic review to be included. Okay, so that time you should not use these filters. So this is a PubMed. So here you can see that it is a PubMed window. We can see that here you can see different field codes. It can be title and abstract, title, text, word, all these things are there. On the right hand side, you can see that these are the Boolean operators. It can be used add with and, add with or, and with not. So these are some of the Boolean operators and field codes. And these are the mesh database. So you can search here cancer. So it will say neoplasm. So neoplasm is the mesh term for the cancer. Okay, so that is how we search for mesh terms. And now if we are doing a systematic review, so Cochrane has a highly sensitive search strategy for identifying randomized trials in Medline. Okay, so this is the version that you can see. This you can follow if you only want to look at the randomized controls trial. So this could be another concept. So once we finish the search on different databases, okay, so we get the studies. One RIS file is we download, okay, and it will have all the studies that are there in PubMed related to our PICO. Suppose 1,000 studies are there. So when we download a RIS file, it will contain all the information related to those 1,000 articles, and that we download, and then we will import it to Ryan. Okay, Ryan is the software that is used for screening. Okay, and Mahe has a subscription for this, and it is very helpful in doing a systematic review. So it helps in deduplication and screening, and everything is documented. Okay, so you will not miss any numbers. So that way we will take it for Ryan. Ryan is for the deduplication and screening. So screening, again, how we are going to select the study. So it is done in 3 stages. First stage, 3 or 2 stages it can be. Initially, it can be done title and abstract together. Okay. So you go through the title and abstract of each article and then see if it is eligible for your review or not. Okay, include or exclude. So at this stage, suppose out of 1,000 you have included 200 articles. Okay, then it will go for full text screening. You have to look for all the full text of 200 articles and see if it is meeting the eligibility criteria. If it if it is meeting your eligibility criteria, and if it has all the information that you need for doing the systematic review. So this is a 2-step or a 3-step process. And again, it should be done by 2 people, independent of each other. So one should not know what other person is doing. They should not be doing it simultaneously. They should be doing it individually, and later on they will see how many conflicts are there. So all this is possible in Ryan. Okay, so there is a blinding that we can do, and 2 people can do the screening, and later when blind is off, that time they can see where are the conflicts, and then you need to resolve those conflicts. And if it's still you are not able to resolve those conflicts, another person, a subject expert or a methodological expert should be consulted whether to include or exclude a study. Okay, so that is why we need at least 3 people for a systematic review. So there should be at least a team of 3 individuals for a systematic review. Okay, now after this, we include the studies for data extraction. So information for screening, again our PICO, time frame, study design, region, country, language, all these pointers we should have, okay, when we are doing the screening at title and abstract and full text stage. So this is how Ryan looks, okay. So you can see on the left-hand side, you have these articles. Okay, one by one. Here you can see there, this is the abstract. So you have to read. So this is the review. So we will not be including a review in our review. So we will exclude this. So that is how you can see all the decisions of all the people who were involved in the screening. Here, this article is selected by everyone. So that way you are not seeing a conflict here because it is already completed. So this is also from one of the review. Okay, and here you can see keywords for exclude. So you can include here, you can add this plus sign, and you can add a key term for inclusion. Okay, suppose you are looking for prostate cancer. So if you are putting a prostate cancer here, so it will reflect. So like this randomized trial, okay, this is reflecting. So that is how it will highlight. So Rayan is very helpful in your screening and deduplication. So this is the Prisma 2020 flow diagram. So where we document our study selection process. So here you can see that all the databases, how many records are identified, what registries we have searched for, how many duplicates we have removed, whether it is with automation tool or records removed for other reasons. Okay, so all these we should be documenting. Okay. So this is the Prisma chart from the review that we took as an example. Okay, laparoscopic versus robotic surgery. So that one same. See, they identified 2,286 from databases, and they had used, I think, 5 to 6 databases. From that, they identified 2,286 citation. From that, they have duplicates removed 1,356. Okay, then their records screen were 760. 760 at title and abstract. This is title and abstract. Okay, excluded 706. So 54 sought for retrieval, means full text. So 54 was searched full text, and then after the screening, 54 articles, these many articles were excluded. You can see here non-randomized, some numbers are there, observational or single arm design are 26 studies are were excluded based on the design of the study, but that they were non-randomized. If you can remember that they were only including randomized controls trial. So all the non-randomized study they have excluded at this stage. Wrong comparator. Okay, their laparoscopic was the comparator. So open RP, non-laparoscopic or mixed approach. So 14 studies were excluded based on the wrong comparator. Okay, and insufficient or overlapping data for outcome of interest, that were 9 studies. So that way, at full text stage, when you are excluding any study, you have to provide a justification or reason for it, and that should also be well documented. Okay, and Ryan has all these things there that you can document. Okay, you can label a study that you have excluded it for wrong design or wrong population or wrong comparator. Okay, so finally they have included studies included in review 4, and reports of included study is 6. Okay, so sometimes the study might be the same, but there might have like 2 publications out of it. So that is why reports are 6. Okay, but the study would be considered as 1, like that. So this is Prisma flowchart for depicting the study selection process and the numbers that at each stage of the study selection they have identified. Okay, and it is a must to provide these reasons for excluding the articles at full text stage. So if there is if there are any questions or something, should we take that, or is it okay? Like, hello, am I audible?
Yes, ma'am. Yes.
So do we have any questions, or is it okay? Means I don't
We'll
have
keep
any
in the
feedback.
we'll keep in the chat box. In the end, we'll
Uh,
take.
there is a
Yeah.
question in the chat box.
Okay. Can you read it? Okay, I'll see. Yes, Prospero registration is mandatory before review article. So review article is when you have done the screening and data extraction and synthesis, everything is done. Prospero registration is only for the your review title and what are the methods that you are going to use. It's not the review results, only till methods.
Ma'am, following another question is there, ma'am, if you can take.
Yeah.
Can it be done retrospective if not done before?
Can it be done
Means if
retrospective?
you have not done Prospero
Yeah.
registration before you have started the your systematic review, can it be
Yes.
done retrospectively?
Yes. So if you have started the systematic review, but it should be registered before you start the data extraction. So it is always advisable that before you start the data extraction for your review, you register the review in Prospero. Okay, so it will not introduce bias. Then maybe based on the findings, you will not tweak your methods. So that is the reason that we register it. Like for even RCTs, we register it in trial registry. Okay, so we go by the methods that we have decided. As a beginner, not done. What solution if journal asked why not done? So if it is a Q1 or Q2 journal, they will definitely ask why it was not registered. Maybe you can register, then you can say that maybe you were not aware of it. So that way you have not registered, but you had a protocol ready, but you didn't register it. So that way you can say if it is a systematic review, then only you need to register.
Yes.
How to identify whether the study I want to do is already done? Okay, as I
Look at
told
all the
you,
records.
yeah, you have to go to the record. So there is a Prospero registry where you can see what are the ongoing reviews. Okay. And then in that also there is a section where they say that whether this review is completed. So status of the project also they update whether it is completed or whether it is published. So all these information you will get from the registry. Okay. So that is one way for ongoing and completed. Another is that you search on PubMed. So PubMed is Medline is the database that you can use the keywords. Like suppose if you're seeing here like robotic versus laparoscopic and prostate cancer, if you're these three keywords, if you're adding, and then if you're filtering it with systematic review, so all the systematic related to that might come. Okay, then you can go through them if it is there or not there. So that is how you have to devote some time for that exercise also.
And in Cochrane reviews, you have
Yes.
specific groups where
Yes.
you can look at
Yes.
the reviews going on, reviews completed,
Completed.
reviews withdrawn. And
Correct. Correct.
there they have to, you have to really look into it and see. And it will be more specific because it
Yes.
is considered, concerning urology programs.
Yes.
So that will
Yes.
be definitely giving this thing.
Yes, yes. So again, here also, like we should also look for Cochrane because Cochrane reviews are different from the other reviews that people do. So their methodology, though we are telling everyone to follow a Cochrane methods, but not everyone will follow. So they will dilute some steps or here and there. Okay, they will not do a grade assessment or something. So Cochrane reviews, you have to register in Cochrane first for
Yeah,
title.
that's it. But if you want to submit to
Yes.
Cochrane, you
Hmm.
have to take that group's permission before starting.
Yes.
And
Yes.
they will
Yes.
look at it and see whether it is being done or not.
Yes.
And then
Correct.
only they will accept it. Then
Yes.
only
Yes.
you can proceed with the Cochrane review.
Yes, yes, correctly. As sir told that if you want to do a Cochrane review, so there is a altogether different process for that. So you need to contact that group where you want to do the review. Then you have to submit a proposal, and then they will see to it that it can be done. And then you need to write a full protocol, and then they will support you with the search strategy and all those things. And then you need to finish the review and it will be published in Cochrane Library.
Yeah,
So that
only if
is
you have taken the permission earlier and they have approved it.
approved it. Yes, yes.
Yeah,
Yeah.
otherwise it is
Yes.
difficult to get it published. Neither they will publish it.
Yes, yes. So
And that
yes, once
approval
they
itself will
approve.
take at least 1 to 3 months,
Yes, yes. That is
unless
the
you are fast on the thing. If you sit
Yes.
on it, it will be prolonged.
Yes, yeah. So sometimes people, that is the reason people don't go for a Cochrane review,
Cochrane
because it
review.
is
Yeah,
very,
it takes too much time.
yes, it takes too much of time. So that you can decide if you would want to do a Cochrane review or a non-Cochrane review. Okay. Any other questions?
Yeah, regarding the outcomes
Hmm.
specifically,
Hmm.
do you have to be specific in the outcome, or you can put an outcome only?
So, sir, it depends. Like in this question, so what are the important outcomes when we say that robotic surgery is better than laparoscopic? So we
Yeah,
have to see what are the outcomes. So that also should be well defined a priori.
and
Actually,
that outcome should be comparator with the other group also.
yes,
Specifically, radical prostatectomy, we are
yes,
talking about incontinence
yes,
and ejaculatory disturbance. Those are
yes,
all which can be compared in two groups.
yes,
And there is no point saying, something which is not comparable between the two groups, that you
yes.
cannot take it as an
Yes,
outcome.
that is what. If a outcome is compared between the two groups and the data is available for both
Yeah,
the groups, then only that article we can include. Otherwise, we have to exclude that.
yeah. When you're performing your title, you got to be more precise and specific.
Yes. So during the full text screening, it is very important to look for all these details and the numbers. Thank you, sir. Thank you for the clarification on Cochrane review process. So, so moving forward from here, so this is the Prisma flow diagram that we use for the study selection process. Next step is the data extraction. So once we have our review question, eligibility criteria ready, inclusion, exclusion, we search on different databases. From different databases, the results that we get, we pull it to Ryan for screening. Again, screening, we go by two steps. One is title and abstract, then a full text screening. If it is meeting the eligibility criteria, suppose 10 studies we have included for our review based on the eligibility criteria that we have framed a priori, we will go for data extraction. So this is the step 4. Okay, so data extraction, it is a process of summarizing studies in a common format to facilitate synthesis and coherent presentation of data, thus helping to identify numerical or qualitative data for analysis. Okay, so basically data extraction is what? Again, it will follow the PICO format. Okay, and there should be a common format. So we have a list where we can compare, like whether population is same or not, where intervention is same or not, where outcomes are same or not. So that is why we do a data extraction. Okay, and again, data can be a numerical data or qualitative data. That depends on your review, which kind of a review you would want to do. Okay, and there are different tools for data extraction. Excel sheet, and this is the most commonly used thing. If you have other software, now Ryan also has a data extraction template, Covidence is having, but all these are paid. So all these tools are softwares are paid, and they are all for even for screening also they can be used, but they are all paid. Okay, Excel sheet you can use, you can have your own data extraction template ready, and you can pilot it with 2-3 studies and see if what data you want to capture, whether it is capturing in the correct manner or not, and then maybe you can further modify it to capture the essential data. Okay. So these are the things that you need to extract from the studies. Suppose you have 10 studies. So for each study ID. Study ID is your last name of the first author and the year of publication. That is your study ID. Report ID if it is. Review author ID. Okay, the person who is doing the review. Citation and contact details. Then eligibility, confirm eligibility for review. Okay, and even at the data extraction stage also, see if it is meeting your PICO criteria or not. even study design, time frame, or geographical location. Okay, so confirm it here at the data extraction itself with each study, whether it is to be included or not. Okay, then methods. What was the study design? What is the total study durations? Then your sequence generation, allocation, sequence concealment, blinding, other concern about the bias. So this is about the methods if it is an RCT. Okay, then participant, the numbers. What was the total number in each group, intervention and comparator both? What was the setting? Okay, if it is a diagnostic criteria also, sometimes they include a study based on the diagnostic criteria as well. What was the age? Then sex. If you are only including adults or if you are only including children based on your review question. Country. Okay, comorbidity, socio-demographic data, ethnicity, date of the study, when it was published, okay, when it was conducted, what was the time period for, what is the follow-up times, all those important methodological details should be extracted. Then about the intervention, okay, total number of intervention group, only if it was A versus B, or whether A versus B, A versus C, A versus D. So all those things you have to see. Then specific interventions, intervention details. What was the intervention? What was the duration? What was the dose? Who was providing the intervention? Okay, then outcomes and time points. Again, time points also is very much important when we are extracting the data. So at 3 months, at 6 months, at just after the procedure. So that depends on the question. Okay, that depends on your PICO eligibility criteria and what is the clinical significance utility of that. Okay, so that way time points also should be decided a priori, and accordingly you should extract data, and extract data only what is relevant to your question, your PICO criteria. The study might be having data for other comparator also. So that you need not to extract. You need to extract only intervention A versus intervention B. Okay, if there is another intervention that has been compared with your intervention A, then you need not to have that data. You need not to extract that data if your eligibility says that we are only looking at A versus B. Okay, so that is there. So for each outcome of interest, outcome definition. So again, it can be there. Okay, unit of measurement for scales, upper and lower limits, and whether high or low score is good. So all those details, that again depends what are your outcomes, what is outcome assessment, what are the effect measures. Okay, number of participant allocated to each intervention group, what was the sample size, missing participant. Okay, summary data for each intervention. If you know the odds ratio and risk ratio, you need a 2 by 2 table. Okay, dichotomous data, and mean and standard deviation for a continuous data like weight, height, all those things, or quality of life. So for that continuous data, and estimate of effect with confidence interval, p value. Then if any subgroup analysis was done, then miscellaneous information also is sometimes very important. Funding sources, key conclusion of the study author, miscellaneous comments from the study authors, reference to other relevant study. This time also during the data extraction, you can go through the reference list of that included article and see if you find any article which was not there in your search that you might have missed. Okay, so that also can be done here. Then correspondence required, miscellaneous comments by the review author. Okay, and even you, if you have some points to make, so all those things should be extracted and noted and documented in the data extraction sheet. Okay, if it is an Excel sheet that you are making. Okay, so then we tabulate the study characteristics. So why we do it? It aids the examination and comparison of PICO elements across all study. So if we see that can we group these studies together or not? Okay, facilitate synthesis of these characteristics and grouping of studies for meta-analysis. So it is very important that we tabulate the study characteristics in a manner that we can compare all these PICO elements and group them for meta-analysis. So this is one example. that you can see that this is the way you can develop your data extraction form in an Excel sheet. Okay, so you can have a serial number, date of extraction, name of the review author who is doing the data extraction, then what is the citation, what is the URL link, okay, study ID here. In the context, if you are only including Indian studies or US studies or high income or South Asia, so you see this is the eligibility component. So yes, continue. Study design, observational, continue. Preventive behaviors, continue. Okay, if something like that you have to see. So during data extraction also you have to see whether it is eligibility criteria is meeting or not. If not, then you have to reject that one. Okay, here to just to confirm that it is meeting the eligibility criteria, and so on and so forth. So study characteristics, methodological details, outcome details, all the sample size, intervention comparator, all those numerical data also you need to extract at this stage. Okay, so here we can see that this way we should be reporting in our review. Okay, you can see two reviewers, WM and SD. These are the initial of the authors, initials. Okay, so independently screen the title and abstract and full text for eligibility, and extracted data from all included trial using a piloted standardized form. Okay, so that is why it is very important to pilot the data extraction form. You can see here that they have mentioned again, it is mandatory that you mention who were involved in the screening, data extraction, quality assessment. Okay, any disagreement at either stage were resolved by discussion with the third reviewer. Okay, until consensus was reached. Okay, so there is a third reviewer role also when we do a screening, even for data extraction also. Okay, for each study and arm, we recorded the study design, country, setting, sample size, inclusion, exclusion criteria, surgical technique, okay, RAP versus LEPRO, nerve sparing status, follow-up duration, the clinical data included, baseline demographics and tumor characteristics, perioperative outcomes. Okay, so all those things. Then all the questionnaires that they have used. Here you can see on the right hand side for the final meta-analysis, the primary outcome was 12-month urinary continence analyzed as a dichotomous variable harmonized across trials. Continent defined as no pad or security pad. Sorry, yes, on ICIQSF versus any pad use or leakage. Okay, so all these details, even for meta-analysis, that is important. Okay, so continuous outcomes were extracted as mean and standard deviation values. So for the dichotomous data, okay, for the binary data, we have our numbers. Okay, how many total numbers were there and how many events were there, and same for intervention and comparison group. And for continuous data we have mean and standard deviation values. Okay, so we should be remembering that along with the mean, it is very important to have standard deviation. And if it is not there, if any information that you are finding at data extraction stage that it is not there in the publication, so you can always contact the corresponding or author of that paper. Okay, and look for the missing information. If they can provide that, you can write to authors and ask for that information if it is not there. Suppose they have just provided mean and not standard deviation, or maybe they have given the data for one group and not for others. So all these missing information, you can always contact the authors, and if they don't reply back, so you can set a time limit, 15 days, 20 days, 1 month, whatever it is. Okay, that also should be set a priori. Okay, and then say that, okay, since we don't have this data, we will exclude this study. So all these things can be done to identify the missing study. You can always contact the author. If they provide, it is good. Otherwise, you need to exclude that study. Okay, so along with the data extraction, it is next step is risk of bias or quality assessment. Okay, so for certain reviews, like if you are go by JBI guidelines, they say that they assess the risk of bias or quality assessment first, and then they include only certain quality of study and they exclude it. But it is not always advisable to include low quality study as such. Okay, so actually all kinds of study, irrespective of the quality, should be included in your review based on your PICO criteria and not the quality criteria. So it goes simultaneously with data extraction. So some people do data extraction first and then quality assessment, but it is more or less simultaneous. Because you are going through the paper, you can assess all these things. Okay, so bias is a systematic error or deviation from the truth in the results. So studies vary in their methodological rigor and thus introduce bias. Okay. Bias can be first in the results of the individual studies will overestimate or underestimate the true intervention effects included in a systematic review. So if you know that for a randomized control trial, you should have a randomization, you should have a sequence generation, you should have a blinding, okay, who all are blinded, all those things are there. So all these details you should capture when you are doing a uh, data extraction for a study in a systematic review. Okay, all those details you should have. Okay, and outcome assessment, who was assessing the outcome, all those things should be captured. And there are different tools that are available for assessing the risk of bias and quality assessment. Okay, so these are different tools that are there, and Cochrane recommends for any randomized control trial that you include in your study, you should use Cochrane risk of bias 2 tool. Okay, so this is an updated tool for assessing the risk of bias of randomized control trial. And for the same, there is a Robvis visualization tool, which is like a traffic light plot. Okay, we'll show it later. Then for non-randomized studies, we have Robbins I, Robbins E. Then for case control cohort studies, we have Newcastle Ottawa scale. Okay, even CASP is also there for case control and cohort studies. Okay. Excuse me. For qualitative studies, it is GASP. All the links are there. We can share this PPT with you and you can just access these link. Okay, everything is linked. Diagnostic accuracy studies, if it is a diagnostic review, if it is diagnostic accuracy review and you are including diagnostic accuracy, so QuADAS 2 tool is there. Even our latest version, QuADAS 3 has also come. Okay, and for assessing the robustness of your systematic review, there is a tool called MSTAR. So it's a checklist. Okay, so these are different tools. There are so many tools are there. You can go to the Equator Network. Okay, that is a website where you can find all these different types of checklist and tools for assessing the quality of a study. Okay, then there are JBI tools. These are JBI critical appraisal tools. So there is a link for it. So all kinds of study, these you can see analytical, cross-sectional, case control, case report. So for all designs, they have a tool. Okay. So you can use, if you are following a Cochrane review, then you should be using a Cochrane risk of bias tool for RCTs. For NRCTs, it is Robbins. And for case control and cohort, it is Newcastle Ottawa scale. But if you are not if you are not doing a Cochrane review, then you can use other tools as well. But for a Cochrane reviews, those tools should only be used. Cochrane risk of bias 2, Robbins I, Robbins E for non-randomized studies, and for case control and cohort, you can use Newcastle Ottawa scale. But for all other reviews, either you can use that also and other tools as well, JBI. So now we'll be a little bit talking about Cochrane risk of bias tool for RCTs. So for assessing the bias in a randomized controlled trial, we use the Cochrane risk of bias tool. since we are talking here about the effectiveness of interventions, where we are only including randomized control trial. Okay, so in the original ROB tool, risk of bias tool, they used to assess the risk of bias as a whole for the study. But in the new version, that is ROB2, we assess the risk of bias for each outcome in the study. If there are 3 outcomes in that study, so we will be assessing the risk of bias 3 times. Okay, for each of the outcome, we need to assess. So for each study can be assessed as having low risk of bias, having high risk of bias with a red color representing it, and a yellow color, some concerns are there. Okay, so to be for a study, if you assess it as a low risk, some concern, on high risk, there are different domains that you need to judge. Okay, there is a randomization process, deviation from the intended interventions, missing outcome data, measurement of the outcome, and selection of the reported results. So these are the 5 domains that you have to study. So if you, I think you already had a session on different types of study design and everything. So you know that these are the important features of a systematic review, the randomization process, if there is a deviation from intended intervention, if there is a missing outcome data, if there was measurement of the outcome, who was measuring, all those things, bias, selection of the reported results, means you are only reporting the favorable results and other results you are not reporting. So all those things are there. So for each of these domains, so it's not a very simple tool, it's a very complicated tool also. So it's difficult to follow. So for each of these domains, we have signaling questions. So in the next slide, we can see that. So domain 1 is bias arising from the randomized process. So there are 3 questions to it. Was the allocation sequence random? Was the allocation sequence concealed until participants were enrolled and assigned to intervention? Okay. So for each of these domains, we have different sets of questions. The response option for the signaling questions can be or could be yes, probably no, no, or no information. So these are the 5 responses that can be there. Okay. Was the allocation sequence random? Okay, if you want to say yes, so you can't just say yes. If it is written as random, yeah, randomization was done. Okay, so this is not enough. You should say what kind of randomize is done. So they have a full detailed crib sheet where they have tell when you have to tell yes, or when you have to tell probably yes, when no, when probably no, and if there is no information, then you should say no information. Okay, so for each of these signaling question, if you have to select one of this response, then you have to justify that response. Okay, and there is a robust visualization tool where you have to document for each of these signaling question. Okay, what was the kind of randomization, who were blinded, okay, all those for each of these domains. So once you do this process, so for each of the domain, this kind of algorithm is there, and for the robust visualization tool, it is already there. Okay, so it will be a automated, it will give whether there is a high risk, if you are answering all those questions, yes, no, probably yes, no. Okay, so like this, if you can see here, in under what conditions it will be a low risk or some concern or high risk. Okay, allocation sequence concealed, yes or probably yes, it will go to allocation sequence random. Okay, yes, yes, they are telling baseline imbalances suggest a problem, no, no, then it is a low risk. So for each of the domain, they have given this algorithm, okay, which is automated in the visualization tool also. You can just explore that. Okay, that link also I have given. Okay, this way, either study will be judged as low risk, some concern, and high risk for that particular domain. So for each of the domain, either it will be low risk, some concern, or high risk. Okay, so like this, overall judgment about risk of bias. So now the study is judged to be at low risk of bias for all domains for this result. Okay. A study can only be assessed as having low risk of bias when in all the domain it is low risk of bias. Okay. See, if in all the domains it is having low risk of bias, then only the study for that particular outcome it is low risk of bias. If it is having some concern in at least one domain, okay, out of 5 domains, if in one domain it is having some concern, then a study is having some concern regarding the bias. If a study is judged to be at high risk of bias in at least one domain for this result, okay, even if in out of 5 domains in one domain there is high risk, then the study will be at high risk of bias. Or the study is just to have some concern for multiple domains. Okay, out of 5 domains, if 2 or 3 domains are having some concern, then it will be having a high risk of bias. So all these algorithms are there that is automated in the visualization tool, and manually also you can do. The crib sheet is there that can be done. Okay, so this is how it looks. So suppose it is just an example. So for study 1, if you see here, for all the domains, it is having low. So overall for that particular outcome, it is low. If in any one of the domain, it is having some concern. So overall is some concern. If study, sorry, the numbers are incorrect in this. Some concern, some concern, some concern in more than one domain, then it is high. And if a study has high in any one of the domain, the study will be at high risk. So that is how these algorithm works, and they've made it. So this is again the same example that we were taking earlier, robotic versus laparoscopic. So here if we can see that for different studies, none of the studies have high risk of bias. Okay, so that is how it is, and it is overall for all the studies they have assessed the risk of bias. So these kinds of 2 figures will be there for your risk of bias. Okay, so this is only about Cochrane risk of bias tool. Okay, that is second tool. See, ROB2. Okay, others tool we will not uh, have here, take it now, because there is a lot of it that is there. So we won't have that much of time to discuss this. Okay, so that is why I have just covered the Cochrane risk of bias tool too, because that is a Cochrane methodology. Since we are following that, we have covered that. Okay, then comes the synthesis. Once your data extraction and quality assessment is done, then the synthesis. Okay, so synthesis, what is a synthesis? Synthesis is a process of bringing together data from a set of included studies. Okay, studies that followed your pre-specified eligibility criteria with the aim of drawing conclusions about a body of evidence. Okay, so when a meta-analysis is not possible, we go for narrative synthesis, okay, wherein we describe the results, or wherein we synthesize the results as narrative, okay. We don't go for a quantitative pooling of the results. We just describe it, okay. In one study, it was there like this. In another study, it was like this, and we compare the results like that. Okay, so there are guidelines for that. There are SWIM guidelines, okay, for the study, for the reviews that can't have a meta-analysis, or where a meta-analysis is not possible. And earlier they used to have this Popey's narrative synthesis. Okay, now there is SWIM guidelines. So this is how a characteristics table will look. Okay, this is study year. Okay, country setting. यहाँ पे, and you can see this is the your intervention, robotic versus laparoscopic, and the numbers are there. What was the inclusion criteria in each of these studies? Okay, for each of the study you should have this. Okay, here only 2 I have taken. Inclusion exclusion criteria also. Then primary endpoints. What was the primary endpoint? Okay, and the secondary endpoint. All these in detailed about the characteristics you should have in a table, so that you can judge whether you can combine the data from these studies. You can combine or pool the data from these studies to do a meta-analysis. Okay. So next is the meta-analysis. So what is meta-analysis? Meta-analysis, if in simpler words we can say that it is the analysis of analysis. Okay. So for RCTs, for case control, for cohort, we have these numbers, okay, or odds ratio or risk ratio, mean, standard deviation, all that data you will get from the study. Okay. Pooled mean, pooled standard deviation, pooled OR there. Okay, effect measures. So that you will get from each of the studies that you will include. Then combining the results of many studies that are included in a systematic review pertaining to a specific outcome to get a common result. That is the pooled estimate. Okay. So from each of the study, you are pooling the evidence and you are providing a pooled estimate of the result. So, meta-analysis should only be considered when a group of studies is sufficiently homogeneous in terms of PICO to provide a meaningful summary. Otherwise, a narrative synthesis is provided. Okay. So, when you are doing data extraction, after that, you should have that table ready with you and see if you can group the studies together. Okay, within the studies also, even if it is meeting your eligibility criteria, sometimes it is not possible to go for a meta-analysis because studies are so homogeneous, so heterogeneous. Okay. So when a meta-analysis is conducted and why it is conducted, to improve the precision, investigation of the consistency of effects across a wider range of populations and interventions, and to settle controversies arising from apparently conflicting studies or to generate new hypotheses. Okay, some studies say that it favors, some studies say that it does not favor. Okay, some are inconclusive. So ultimately, when you're pooling the study data from like 5 studies or 6 studies or only 2 studies, then what is the outcome? Okay, what is the pooled evidence? What is the conclusion that we get? That we get through the meta-analysis. Okay. So here you can see this is again the same example that robotic versus laparoscopic we were taking. And you can see here that for this particular Figure 4, forest plot comparing 12-month erectile function potency between robotic and laparoscopic. Okay, you can see here that from robotic, you have these numbers, events, total. Okay, for each of these studies. So for this meta-analysis, they have included 3 studies. Okay. So suppose for a systematic review, you have included 6 studies, but for a meta-analysis, you might only include 3 studies because for that particular outcome, maybe data has come only from 3 studies. Okay, so that we have to keep in mind. So it's not like 6 studies we have included in our review. So meta-analysis also will be conducted with those 6 studies. We have to see that in terms of PICO, how many studies are matching, how many studies are homogeneous, so that we can do a meta-analysis. So you can see here for robotic versus laparoscopic, we have events, we have total. Okay, out of 52, 33 had 12-month erectile function. Okay, then for laparoscopic, again, events and total out of 60, 23 had that. So this much data you should have with you when you are doing a meta-analysis, okay, for all these studies. So Revman software, so for Cochrane, we should be using Revman software, or if you are going for a Cochrane review, they will help you with all those subscriptions and everything. Okay, so you will get a subscription for Revman. So this is the analysis that has been done in Revman. No, not in Revman. I'm not very sure whether it is done in Revman. I have not seen that way, but it can be done in Revman, and other softwares are also there. Okay. So this data is very important. So even if, okay, if you don't have this data from any of the studies, then it cannot be done. So then weight of each study. This is the risk ratio from each study, and this is the pooled estimate. Okay. And this will be calculated from the Ravman software. You don't have to do it manually. You just need to have these numbers with you, and that is what you need to feed into the Ravman. Okay. So here, if we can see that this is the forest plot here. So you can see that this is line of no effect, and here on the right hand side it favors laparoscopic, on the left hand side it favors robotic, and this diamond is the pooled estimate. Okay, so here it is saying that it is still favoring laparoscopic over robotic. Okay, the study says that it is favoring laparoscopic when it comes to this particular outcome. And these are the individual study data and the class interval, okay, and weight of the study. Okay, every study is favoring the laparoscopic. Okay, and in the second you can see here, so this is the pooled estimate, the diamond. Okay, and then this is another outcome. In this outcome, see, they have included 4 study. And this is also a dichotomous data, okay? Binary data, events total, A versus B, robotic versus laparoscopic. So this data you should have. So here also you can see that for this particular outcome, forest plot comparing positive surgical margins overall between robotic and laparoscopic, okay? Here you can see that there is the evidence is inconclusive. Okay, there is, okay, it is neither favoring robotic nor laparoscopic. So all these things you should keep in mind. Okay, and you can see here that random it is written. Okay, random means there are 2 models when you are doing a systematic review. One is random and one is fixed model. When there is homogeneity in your pico elements, then we go for a fixed effect model. Okay, otherwise we go for a random effects model, and mostly it is random effects model that is followed. Okay, until and unless you have that complete homogeneous group, you go for a random effects model. Okay. So this is the example for a continuous outcome. Again, from the same reference we have taken, you can see here that this is forest plot comparing operative time minutes between robotic and laparoscopic. Here you can see that data is mean, standard deviation, and total. Okay, so these kinds of table you need to make when you are doing a data extraction for meta-analysis. Okay, this is the data that is important. So for both robotic and laparoscopic, from all these studies, this data should come. Okay, then we can see here, again here also it is overlapping. It is not completely favoring the laparoscopic method. Okay, so this is how that meta-analysis and how to generate a forest plot. This is called forest plot. Okay, this is the pooled estimate. This is the individual study weights and the class intervals. Okay, and next comes, now that we have completed our review question, eligibility, search, screening, data extraction, quality assessment or risk of bias assessment. Then we have assessed the data, whether we were able to do a meta-analysis or not, all those things. Then comes the grading of, excuse me. Yes. So next step is the grading, grade assessment, which is the full form is grading of recommendation, assessment, development, and evaluation. Okay. So again,
Arun Chawla, sir, you want to say something?
Yeah, ma'am, are you comfortable continuing or
yes,
you?
yes, no, sir, that is okay.
Okay,
I just
okay,
had
ma'am.
some water. Yes, thank you. Thank you so much. Yes. So now that grade assessment is there, okay, so once we have completed all the steps, whether meta-analysis was feasible or not, we do a grade assessment. So again, if you might have gone through the systematic reviews, you might have seen that a grade assessment is not always done in a systematic review until and unless it is a Cochrane review. Okay. So if you are doing a Cochrane review, okay, a grade assessment is a must where you are grading the evidence quality that you have generated. Okay, how much we can rely on the evidence that we have generated through a systematic review. So that is what we are not going much detail into all this, but this actually should be done if it is a effectiveness review or if it is a Cochrane review. And otherwise also, if you are doing a Cochrane review, but you might have seen that in some of the non-Cochrane reviews, they don't go for a grade assessment, and it is a very important step in guideline development. So we are not considering Abhi right now for guideline development. That is altogether a different process. Okay, and it takes a lot of time to discuss all these things. So I'll just touch upon all these aspects of a grade assessment. Okay, so when we are including an RCT, okay, if we are only doing a systematic review of RCTs, then we do a grade assessment. Okay, this is the grade assessment. You can see here, this is these grade domains you can see here. Risk of bias, inconsistency, indirectness, imprecision, and publication bias. Okay. So see, it starts with the formulation of a question, select outcomes. It can be critical or important outcomes. Okay. Then outcome across studies, create evidence profile within grade pro, rate quality of evidence for each outcome, high, moderate, very low, low. Okay. So when we rate an RCT, evidence from the RCT, when it start with the high and we downgrade the evidence. Okay, it can be in terms of risk of bias, inconsistency, indirectness, imprecision, and publication bias. Okay, risk of bias, you have to see overall risk of bias in the studies. Inconsistency, you have to see whether there is inconsistency in the reporting effect measures. Then indirectness means if the evidence is coming from the PICO that you have decided or not, okay, or there is deviation in the PICO, even though you have included. Then imprecision, and then publication. Imprecision is about the diamond. Okay, and then publication bias is in terms of the studies, whether you have included all the studies that are there or not there. So there is a graph for that, that is a funnel plot. Okay, that we are not uh, discussing right now, because these are the most critical important steps, though I'm not discussing it right now. So we judge for each of these grade domain, we grade the evidence for each of the outcome. Okay, it is assessed for the outcome, the pooled evidence, that the pooled evidence that we have got. Okay, so it is judged for that. And then down there is a guideline development process, that is altogether a different domain that we are not discussing right now. So for each of the outcome, the evidence that we assess is either high, moderate, low, and very low quality. Okay, and based on those, risk of bias, inconsistency, indirectness, imprecision, and publication bias. Okay, so when we say that we have assessed the grade as high, we say that we are very confident that true effect lies close to that of estimate of the effect. Okay, and the same way, moderate, low, and very low. And if we have included here, see, if we have included only observational study, then we will start with the low, and we will upgrade the evidence. Okay, based on large effect, dose response, and other confounders. Okay, so on that basis, so it is again it cannot be summarized in just like this way. So we need separate 2-3 days of workshop for grading only itself. Okay, so these are just the points that we need to consider for a grade assessment, only these things. Okay. So that is how we assess the grade assessment. Again, there is a grade handbook for that, and there is a grade software that we utilize for this assessing the grade. Okay. So this is again the same study. So for each of the outcome, they have assessed the evidence. Okay, so they are saying risk of bias. There is serious risk of bias for 12-month urinary continence. Okay, inconsistency, they are telling not serious. Okay, so there are pointers again for that. When you say that there is inconsistency, when you say that there is an indirectness or imprecision like that. Okay, and then not detected, this is the pooled estimate, and then grade quality moderate. Okay, so these are all the steps of a systematic review. So when you are developing your protocol, all these methods should be there, that what you are going to do. So this is ultimately the final systematic review process, where we plan for the review. We have the protocol, identify the issue and determine the question. We look for the study. Okay, we select the studies from a pool of studies, okay, in 2 steps. Then we extract data from the study, we assess the quality of the study, then we combine the data. We either summarize it narratively or through a meta-analysis. Okay, then we discuss and conclude overall findings, and then we have a systematic review, and then there is dissemination. Okay, so these are all the resources that I have used. There is a Cochrane handbook. Okay, there are other articles that I have cited. So all these things I have used for this. I think for now, yes. I hope it is helpful and I could convey the steps of a systematic review.
Yeah, ma'am, actually, what I'll say is it was just an expert teacher at its best. So, a lot of information we have gone. But before we just go and ask the opinion of our other members, let us invite Dr. Arvind Ganpale to give his expert comments.
Oh,
Arvind Ganpale is past associate editor of our Indian Journal of Urology, which is an
oh,
official journal of our society. And
okay.
he is also into systematic reviews and meta analysis.
Yes.
Arvind, are you there?
Yes,
Uh,
thank you very much, sir. In front of madam, I feel I am just in nursery as far as systematic
Mm,
review goes. The
no,
way
sir,
she has
nothing,
talked.
nothing. Just no,
So,
that is not the case. I have just some experience with nothing like that, sir, please.
but I would like to summarize what you said. I
Yes,
have got two questions for you, but before that, I would just like to summarize what I got from this talk,
yes.
which I must really appreciate that
Hmm.
over the past 2 hours you have really summarized, which is actually a material which has to be discussed in a workshop of over 7 days.
Yes, yes,
I
sir.
myself have attended one of these workshops at Mahe,
Yes.
as I'm doing my PhD at Mahe. It is a systematic review course for 4 credit points, and
Hmm.
I do understand that this particular thing is covered over an workshop which we attended over a period of 2 months.
Yes, yes.
So thank you very much for summarizing everything.
Thank you, sir.
Just for the sake of the attendees, I would like to say that it's very important that a few words which everybody should remember before everybody signs off is that everything should be done a priori. That is one thing that everybody has to remember. It is absolutely mandatory, as Dr. Sardana had raised this point. I felt that it was a very relevant point as to whether we should be registering the protocol. And it is mandatory that you should register it with Prospero even before you start thinking about the search string. We ourselves had faced one problem in one of the systematic reviews wherein we had registered ourselves, but somehow the search string we could not find what were the words for the search string. So I feel that that is one thing that I learned from that particular thing. As madam just mentioned, that it is mandatory that we have to do the search in at least three databases: Embase, PubMed, and Scopus. Others are optional, but it's very important. For the sake of the residents, I can see Varun and Dr. Aishwarya who are attending. I think it is very important that you have to follow the PICO mnemonic. it is very important. That is the first thing of doing that thing, of doing a systematic review. The steps of the systematic review that Madam mentioned were obviously it starts with title abstract screening, then it goes with screening, full text, and then data extraction. Each of it has got very important, it has to be done by experts. Madam also mentioned one very important thing, that systematic review should have at least 3 members. Unless you have got 3 members, which can include subject expert, domain expert, and a person who is very well versed in data extraction. As you can see that it is a very labor intensive, and the people should have their the people involved should, this should be their area of core area of interest and competence. So we have to include the proper people. But one challenge that I faced is that, as Madam just mentioned, that among the team members, 7, 8, 10 team members we include, and out of that only 2 or 3 are working, rest are not working. So in each step, it is very important that 2 people should validate. Like it is title abstract, it may be data extraction, it has to be validated. Otherwise, Covidians will always say that there is a discordance, and then it has to be validated by the third person. So all of the team members should be involved in it. As Madam was mentioning, a few important take-home points are that what I feel that the institute, like Mahe has got this particular thing, but the institute should have access to Rayan, as well as the institute, if you want to do title abstract screening, we should also have access to Revman, because Revman is one thing wherein you see all those beautiful forest plots, you see heterogeneity, ROB, everything you will be able to understand on Revman. So you should have one person in the team who actually understands how to operate these systems. It may be Revman or anything, even as simple as how to register yourself in Prospero. And I remember in one of the credit course, credit point course, there was one madam who also, like you, was involved in the guidelines committee, and she took a talk on grading, the grade for almost 3.5 hours.
Yes.
And you so nicely summarized it in 10 minutes, but it is a topic for almost 4 to 5 hours, grade assessment. With this, I must say thank you very much, madam. It was really a nice summary for everybody to understand. One question for you, madam. Actually, 2 questions. One is there is a thing that comes up very frequently called as topic modeling. So, can you throw some light, like which are those topics wherein we can follow this particular thing of topic modeling?
Sir, can you please just
I will give
Yeah.
you a background for this, that in one of our studies wherein we had registered ourselves for Prospero, in Prospero for the aortorenal ganglion.
Okay.
We went to the PSPH, and Kamath madam told us that this is not a good topic for systematic review. This is a topic for topic modeling, because the literature is very sparse, and the literature is spread across a variety of species such as sheep, goat, dogs, and very few human this thing. So she
Okay.
said that there is a new thing that has come up using the LLMs, wherein you can do a topic modeling and you can extract the data. So is it necessary that we should know something about topic modeling, and this is exclusively kept for the experts?
Yes, so I am also like not very well versed with topic modeling, but what I can say, maybe a bibliography, like a bibliographic bibliometric analysis we can do. That is what I think maybe she meant topic modeling. But when we are not sure how much information or how much published literature is there in what, so we can also go for a scoping review first to see what kind of studies have been done, and in which population it has been done, or maybe in what context it has been done, like how you gave that example that it has been done on mice, rats, and all those things, but not in human population or something. So maybe we can do a scoping, or maybe that is what topic modeling, that is what I think she meant. Like we told that scoping review is a precursor to a systematic review. So if we are doing so, we get an idea like what kind of studies are there. So what is the gap? So whether there is a possibility of a systematic review or not. So maybe on those lines, I think it can be done.
Got it, madam. Thank you very much, madam, and thank you, sir, for the opportunity to make a few comments. Thank you very much.
Thank you, Arvind. May I go to Dr. Janil? Dr. Janil is chairing our section of collaborative research under the aegis of USI. He is also into various research across the different zones, mainly into uro-oncology. Jinil, how we should, your comments on that, how we should think that which are our weak points when we are taking the systematic review? What from Madam's talk you understood probably are the
No,
areas
it's
which
a
are
vast
weak?
topic. It's a vast topic. It's not like we have to create a team, and basic thing is we have to start in each institute. We can take small issues and just formulate a study, and with somebody like Madam who is an expert, with their guidance, we can just we have to start. Then only we will understand all these things what she told.
Yeah. Okay, Jinil, that's a good idea. I have one question for you, ma'am. If you
Yes.
can take it
Yeah.
in the chat box.
Yes, sir.
That,
So the question is, so just adding to what sir was saying, so it's when we are deciding like review question, so whether we should go for it or not. So it should not be only a one person's job to decide on a topic. So we should have like everyone in the team. So first we should make a team and then we should see. So that is why we do a scoping search before even we start for a review. So we see the possibility and feasibility of doing a review. So we have expert guidance, we have subject guidance, then we have methodological guidance, whether what kind of a review can be done. So like I have earlier shared in the slides that there is a right review. You can just click on right review, so it will give you a different options. Okay, there are multiple options that what you would want to do, whether you want to compare A versus B, or whether you want to see through the risk factor, or whether you have a time limitation, or whether you want to do economic things. So it will give you an idea of what kind of a review you can do. Okay, and then it will also give you the guidelines. What are the guidelines for that particular review, whether it is a rapid review, or whether it is a scoping, or a systematic, or a diagnostic, or an umbrella review. So that way all these tools are very helpful, and more so it is a collaborative effort. I feel that a team should decide, because expert subject expert has the knowledge of the domain, what is the current scenario, and what a kind of studies are there, and also through a scoping search a priori, like I told, like we will see like different databases, what kinds of review have been done. So if a review has been done like last year or so, so there is no point again doing a same review. So nowadays there are living systematic reviews also. So for a particular question, if a new study has come, they will add the data or pool the evidence to the previous analysis. So that is how it is there. So there is no point in duplication also. So that way maybe something can be done. And in the chat box, I have how to ensure that we are
Actually,
not.
it is the
Sorry, sir.
actually, as the reviewer, you are the author of the review. It's your responsibility to update every 3 months. If you don't update for 3 to 6 months, they will even withdraw the review. So that is the responsibility of the primary
Of the
author,
authors,
so that
yes.
he has to update if there are any new studies which are coming.
Yes, yes,
And
yes.
this topic modeling and text mining,
Hmm.
it is on the news blogs, some articles which have come. Those are the things which you sort of, collectively look at it, whether you can group them into some kind of a thing.
Yeah.
Like these things fall into this line, or these outcomes are this line. So something like that you have to do. And out of them, get the data and see. So that is text mining and topic modeling. So basically, you are looking at news blogs, news articles like that. It's not like already gone into some database. It is just you are seeing the other resources and see whether it has been already done, whether it can be done.
Done. Okay. Thank you so much, sir.
ma'am, you can take the last question also.
Yes.
Is from Satya.
Yes.
He is a avid follower of our all the research methodology classes. How to
How?
ensure that we are not missing important studies during literature search?
Yes, so again, so it is again a standard process, like how I told that we first should have a PICO thing ready with us, then we should have the important concepts. We should see that if we are combining those concepts, will we get those studies that are relevant to our review question or not? Then we need to search. That is why we need to search on multiple databases. We need to look for the gray literature. We also should be doing a hand searching or contacting experts,
Yes.
also going through the reference list of the articles that we have included, so that we should not miss any studies. And
Conference
yes,
outcomes.
even
Yeah, all this
conference,
you got, yes, you got
yes,
to see, look at those.
yes, conference abstract also you can see. And if there is a conference abstract, and then you can see if it has been it is published
Published
or
or
not,
not. Yes, yes,
so and
yes,
then even now we have this preprints also. There
yes.
also they can have a look. Medrix, I guess that is one of it. And then and even when you complete your review, before submission, I think we should rerun the search. If because once we finish the review, it's
There
already
might have
being
some
like,
other article which has come.
yes, so maybe some new article might have come. So that also we should try to include before we submit to the journal. So that exercise should be done. So these are, I think, some of the ways that we should make sure that we should not miss any studies.
You will collect more studies than miss anything. Very rarely you will miss
Yeah.
it.
Yes.
And especially those studies which you are not included. And you got to be very clear with the exclusion criteria,
Right.
why you have excluded. Because
Yes.
that author can question the Cochrane review group and ask
Yes.
them why my study has been this thing. So that
Yes.
is another important issue which we have to be very clear. And all
Yes.
the three people who are working should be in consensus
Yes.
regarding the exclusion criteria.
Yes. Yeah.
Yeah. I think now it's time to sign off. I'll request Honorary Secretary Dr. Chandramohan to please come for his
Yeah.
closing comments, Sir Chandramohan.
Sir, thank you very much once again, Dr. Vijayashree Dhyani Madam, for an extensive summary about this topic. And I also thank Dr. Arvind Ganpale and Dr. Ginil Joseph Philip Raj for actively participating. Some of the juniors are also asked the questions. And this link will be recorded and it will be immediately posted in the YouTube of the Association of Southern Urologists. So those who missed, we will give them so that they can leisurely listen. I once again thank Dr. Arun Chawla sir for these two online sessions, which on short notice conducted. Still 25 to 30 people attended at constant this thing. And we are also having, dear friends, on coming Saturday, Sunday, a physical meet both on research activity as well as the artificial intelligence usage in the research activity. This is again done at Stanley Medical College, Chennai, with the help of Dr. Paramjot and the team of the Stanley Medical College Urology Department, along with, of course, Dr. Arun Chawla sir and all the scientific committee. Once again, I thank for this excellent session. Thank you very much. With this, we will conclude the session.
Thank you, Chandramohan. Thank you, madam. Thank you,
Thank you so
everyone,
much,
for
sir.
joining.
Thank
Yeah.
you.
Thanks.
Thank you, sir. Yeah.